the chance of you having sex with somebody who has an STI or HIV is much higher than you would be in wards 1 or 2, simply because the rates are higher in those wards.
Hey, welcome everybody to another episode of Positive Voices. I'm your host, Malachi Stewart.
I'm T. Pearson Hall.
And today we have a very special guest to talk about something that I know you all are curious about, myths.
Yes.
Listen, in the world of HIV, there is so much myths. There's a lot of myths in the world of healthcare, sexually transmitted infections / diseases. And here we have our guest, Bryce, with us. Bryce, introduce yourself. Let people know who you are and what you do.
Hey, my name is Bryce Furness. I am a physician. I work for the Division of STD Prevention at the Centers for Disease Control and Prevention, but I have been embedded in the Department of Health in Washington, D.C. since 2002.
Yeah, so you're not new to this. You're true to this.
I'm not new to this.
You're true to this. We've worked together. We've worked together in a few clinics before, so I definitely have experience with you professionally, and you're definitely one of the best. So I'm interested, before we even get into some of the questions people had, like on the streets and in the community, what are some things that you would like to address? Just myths that you hear or miseducation? And if I could start with one, what does it mean, for example, to be clean?
It's a good one because I hate that word. And it's used, the way that it's used, at least in the clinical setting, is in a very derogatory form.
Yes.
And so it tends to be patients that are having symptoms.
Okay.
So they probably have a sexually transmitted infection, and they are talking about their partners in that, well, I thought they were clean. And I don't think it comes from a place of self-awareness where, like, you saying that means that you right now are unclean. You are here for an unclean reason. And so to me, there's just the discordance between how we use that word and what we think it means. It's always somebody else that's clean or unclean. It's never us.
Yeah, that makes a lot of sense. What are some other things?
So I'm very proud of the fact that the DC Health and Wellness Center, our pre-exposure prophylaxis clinic for HIV, we have more than 75% of our patients are brown and black, MSM, and transgender females on the medicine to prevent HIV. That is the way to end the HIV epidemic. That and
Absolutely.
U equals U are the two steps that are going to make HIV a completely different animal in a couple years. And for someone who's been in this for a long time, who was actually in HIV before highly active antiretroviral therapy started, this is all a game changer. So I'm very proud of the fact that most of the patients that we see at the clinic that are getting the pills to prevent HIV are MSM and trans of color. What I want everybody to know is that there are no barriers. You do not have to have insurance. You do not have to have a medical home. DC and the DMV has safety nets upon safety nets for HIV prevention and HIV treatment. There is no reason for anybody who's HIV positive to not be on treatment. There is no reason for anybody who's HIV negative, who has had a bacterial STI or multiple partners or engages unprotected receptive anal intercourse, to be on pre-exposure prophylaxis. None. So that's the one myth that I just want to put out there up front. There are no barriers. In DC, and the DMV has safety net upon safety net, so there's no reason, if you want it, to not be on it.
Wow, good one.
That's good.
Yeah, another question for you. Why aren't lesbians at the table for these conversations?
That's a very good question. It's sad, but I think that when we think about lesbians in the world of sexual health, we think about women who have sex with only women. And women who have sex with only women are at lowest risk for STIs, including HIV.
Oh, wow. Okay.
But women who have sex with men and women tend to choose higher risk men. And so women who have sex with men and women are at higher risk for HIV and other STIs than women who have sex with men only.
Wow.
I didn't know that.
Yeah.
That they choose to risk, that it tends to be higher risk men. That's information to me, and I've been doing this for a while.
We just published a study based on the parish health units in Louisiana where we were looking at extragenital screening, and the numbers weren't high enough, but it appears that women who have sex with both men and women have a higher incidence of bacterial sexually transmitted infections in the rectum and the throat versus women who have sex with men only and women who have sex with women only.
What kind of infections are bacterial?
Bacterial infections are gonorrhea, chlamydia, syphilis.
Okay. That makes
Viral are things like HIV, human papillomavirus, which causes warts and cancers, and HIV, HPV, HIV, herpes.
And herpes. Got it. So you talked about, and you brought up wisely that like lesbian women are a part of the conversation. Can I ask you what assumptions are made about men who have sex with men? Like, because it seems like sometimes there are a lot of assumptions that men who have sex with men only have sex with men. Is that true? And how does that look?
That's a whole, we could spend an entire episode talking about So I'll tell a story. Through Whitman Walker Health, we are in the Crew Club, which is the only real bathhouse in Washington, D.C., and we do STD screenings.
Yes.
And we typically do that Tuesday evenings and Tuesday nights. And part of the process of enrolling to get tested for HIV and STIs is demographic questions. So we have men who are in a towel in a club that does not allow women, and the only reason they're there is to find and have sex with other men. When you ask them what their sexual identity is, they'll say heterosexual.
Wow.
So that's one end of the spectrum. The other end of the spectrum is there are a lot of young clients in our clinic who consider themselves bisexual, but haven't had female partners in years. Like specifically, I ask about partners in the last 3 months, in the last year, and they consider themselves bisexual, but it's been years. I've known them for a long time. It's been years since they've had a female partner. You know, it's identity, and identity and behavior often don't jive. And then you have men who have sex with men, which is a behavior. It's not an identity. You have gay men, and then within gay men, you have a whole bunch of different types of gay men. You have platinum gay men and gold gay men and silver gay men. And the joke is, you know, whether or not they've been through a vagina or ever seen a vagina. Okay. So platinum gays basically were born by C-section and have never been with a woman.
Oh, okay.
So they have
I've never heard platinum before.
They have never ever seen a vagina, been through a vagina, nothing. Then you have gold that are basically they were born through the vagina, but they've never been to one since then.
Okay.
And then you have the silvers and the bronzes. And so and it's also, you know, it's temporally there's an evolution. And that's why, you know, oftentimes people just ask about sexual orientation and gender identity once, but that evolves. And a good example of that is when I ran the transgender health clinic at Whitman Walker Health, there was a man who was in the military who was married to a woman.
Okay.
This man realized that he was a transgender female, and so we started the process. He froze some sperm before the process started. His wife was 100% heterosexual. They're now still together. They have 2 kids, and she's now 100% lesbian because she was in love with the same person who was initially a male, transitioned to a female. They're still together. They have 2 kids together. And so if you would have asked her when she first met this man, what's your sexual identity? I'm 100% heterosexual. Go talk to her now. She's like, I'm 100% homosexual.
Yeah.
So
it's about evolution.
It's a spectrum, and it changes over time, especially with the youth.
And thankfully that we live in times where people are able to be who they are. But I really appreciate you clearing up the difference between behavior that people assume and identity. Identity and behavior, like you said, doesn't always match. One thing I want you just to clear up and say, I guess in a way that people can understand. We talk about you equal you a lot here on the show. We talked about, you know, what it means to be undetectable. Can you kind of just explain what that means and let people know, can they trust that?
Yes, they can trust it. Like it's science, and I'm a scientist, and the science behind that is amazing. What U equals U means is that HIV positive individuals that take medication to get their viral loads undetectable, quote unquote, have a very, very low risk, approaching 0, of transmitting that virus to somebody sexually. So when you're talking about U equals U and you're talking about viral loads, you're measuring what the viral load is in the blood. Okay. So when it's undetectable in the blood, it's even less detectable in body fluids. Ejaculate, pre-ejaculate, vaginal fluids. So it's even less likely to be there and be able to be transmitted. So that's really what they're talking about. They're basically saying that when you can't identify it in your blood, you can't transmit it to other people. And when they can't identify it in their blood, it's even less likely to be in the other body fluids.
Good, thank you for that. So I've kind of heard PrEP kind of mentioned quite a bit. Can you talk a little bit about what that is?
Yeah, I mean, PrEP it's going to be one of the 2 pillars that ends the HIV epidemic. It is basically a pill or a shot that individuals get in order to prevent HIV. Okay. And there are criteria, typically CDC, the Centers for Disease Control and Prevention, has criteria for who should be educated about PrEP, who should be started on PrEP, who should be offered PrEP. And often those revolve around things like number of sexual partners, whether or not they've had a bacterial STI, gonorrhea, chlamydia, or syphilis within a certain window period, whether or not they have drugs while they're drunk or high. Like there's certain criteria. The reality is at the DC Health and Wellness Center that we will put anybody on PrEP who wants it. And I was forced to deal with one of my own internal biases because I had a 65-year-old heterosexual man in a wheelchair come to clinic and wanted PrEP. Wow. And I at first was like, he's in the wrong clinic. Like he's here for tuberculosis or he's here for something else. I was wrong, and I learned a valuable lesson. And he knew. He was very smart. Basically, he often paid for sex. And so he was heterosexual. He was in a wheelchair because he'd been hit by a car. So it was a temporary thing. He's ambulating now with a cane, but he identified his own risk. He knew that basically I pay for sex. Like I have transactional sex all the time. And being on PrEP would give me an added sense of security. That's not one of CDC's inclusion criteria.
Okay, got
So
you. Thank
we
you.
will start anybody on it that wants
Even
it.
if they have no money.
Even if they have no money.
We got to keep saying it because
Yeah,
I've
we
been out
do.
to so many restaurants. I've had so many waiters, mostly college students, who are like, hey, I'm not on PrEP. They find out what we do. They hear the conversation at the table and like, hey, I'm not on PrEP because I can't afford it. Or I don't want my mom to find out. I don't want her to see that I'm being tested every 3 months. And ask me why. And so I'm like, oh, what's ways around that? We do this. And at the time, me and the PrEP coordinator had each other's numbers. So I was sending them on Monday. By the end of the day, they were walking out with PrEP and, having had their first test. But I love that you're like letting people know that.
There's
What
no
about
barriers, yeah.
Doxy or doxycycline PEP? Like, what is that? Talk to us
So
about that.
doxypep is newer and controversial, and it's controversial within the lens of antibiotic resistance or growing antibiotic resistance. But doxypep is basically a way that gay men, and it's really been only shown to be efficacious or really work with gay men, where they can have high-risk events and take 200 milligram doxycycline pills, so 200 milligrams of doxycycline once, hopefully within 24 hours of the event, but definitely within 72 hours of the event. And if they do that during these over time for these high risk events, they're much less likely to have chlamydia. They're much less likely to be diagnosed with syphilis because doxycycline can be used to treat both chlamydia and syphilis. But interestingly enough, in a couple of the studies, they're also less likely to have gonorrhea. So it seems like this doxypep, post-exposure prophylaxis is what PEP stands for. When you have an incident and you take this medicine within 72 hours, but hopefully within 24 hours afterwards, you're much less likely to be diagnosed with some of the more common STIs, gonorrhea, chlamydia, and syphilis. It's interesting to me because there is pushback from the antibiotic resistant crowd that this is, we're going to be using doxycycline too much, all these other types of things. The reality for me in our clinic is we've been offering it for a long time, way before there was a name on it. Like you were familiar with U equals U before they named it U equals U.
For sure.
I was very familiar with doxypep before they named it doxypep. And when we give guys in our PrEP clinic or HIV positive guys in our ART clinic a certain number of doxycycline pills and then check to see how much they've used over, it's usually a 3-month period between appointments. I just had a patient I saw yesterday who was given 33 months ago and hasn't used any.
Oh.
And we have starter packs. We gave out starter packs at Capital Pride. They were very popular. And in those starter packs basically are 6 pills. So it's 3 different doxypep. And what I counsel my patients is that it's not for your regular partners or your partners you're comfortable with. This is not for your partners who you talk about sexual health. You talk about HIV testing. You know they're HIV negative and you know that they were tested within the last 3 months. You know that they get regularly screened for STIs and that they don't have STIs. That's not who you use doxypep with.
Okay.
We all have hooked up with someone where the next day our gut was just telling us that we shouldn't have done that. That's when you pop the 2 doxycycline
This is the
pills.
grinder hookups, the jackups, the
Exactly.
A9, the I went to the glory hole and didn't see who the person was. These are those kind of hookups.
Or the hookup where you try to have conversations about sexual health and by no eye contact and other things that they're probably not telling you the truth.
People out here shifty. I know we have a lot of questions that we have from the community, but the last thing I just want you to clear up, because I get this all the time. Safe sex. Does that mean condoms?
I think safe sex is one of the terms. There are several terms that just need to go away. Safe sex is one of them. Clean is another one. High risk is another one. Risky, high risk, like all of those terms. For me, and this is where safe sex depends on the person and the situation. So we know one of the criteria for inclusion for pre-exposure HIV prophylaxis is number of sex partners. But to me, a guy who has 3 partners and never uses condom for receptive anal intercourse is much less safe, much riskier, all those terms we don't want to use, than a guy who's had 20 partners but uses condoms 100% of the time with both receptive and assertive anal intercourse. So it's a lot more about the quality of the partners than it is the quantity of the partners. And so that's why I have issues with things like clean and issues with risky and things with safe sex, because it depends. You also have situations, you have serosorting. And so if you're an HIV positive individual, and you're having sex with another HIV positive positive individual, you are going to be less likely to quote unquote have safe sex than you would otherwise.
Right.
Okay.
And so that for them is safe sex. Zero sorting is a version of safe sex. Another instance could be HIV negative men are more likely to be an assertive partner with an HIV positive partner because it's less likely to be trans. So it's, for them, that's safe sex. Like they're thinking about this, they're trying to minimize risk, and it's all about harm reduction. And I think when we talk about safe sex, it's a one glove fits all, when the reality is it's steps for everyone. And it's everyone's got to figure out how they are going to reduce their own risk and feel better about the sex they're having, the people they're with, and always focus on pleasure.
Thank you for that. One more question before I kick it to the streets, because we had folks outside that had some questions, wanted to answer some questions. Can you explain to us a little bit about why the Black and brown community numbers are so much higher when it comes to STIs and HIV?
Yeah, that's a tough question.
Yeah.
If I knew the answer to that, I'd probably be a very wealthy man. But I think in my experience,
Me too, right?
Yeah, I think in my experience, it's multifaceted and there are multiple things. I think one of them is something that we call prevalence pools. So unfortunately, if you live in Ward 7 and 8 in the city and you're having sex with somebody from Ward 7 and 8 in the city, the chance of you having sex with somebody who has an STI or HIV is much higher than you would be in wards 1 or 2, simply because the rates are higher in those wards.
Okay.
So the prevalence pools definitely play a role. I think that unfortunately, access to care is a big one. Obviously, you're less likely to have an STI, especially a sexually transmitted infection that doesn't cause symptoms, if you're able to get screened and treated more frequently.
Okay.
If you're in the southeast of the city, you don't have a lot of options, so you're less likely to be screened if you're not having symptoms. And we can pass on sexually transmitted infections, including HIV, without having any symptoms. So I think prevalence pool is big. I think access to healthcare is a big issue. And then I think stigma and shame are a big issue. I think that within certain communities, especially communities that are very faith-based driven, people aren't honest and transparent about sex.
Yeah.
And that leads to everything from young folks not being educated about how to prevent pregnancy or how to prevent STIs. It leads to this whole issue of young folks not knowing that they could go get tested and treated for STIs, vaccinated for STIs without parental consent, without having to pay anything. Like that's all part of the process because it's not talked about. It's not something that's passed on. And then I think the other end of that is that you have older males who are HIV positive that do not disclose their status to their younger partners because of shame, because of stigma. And even to this day, I have patients in my clinic that sometimes when they travel, they don't take their PrEP, they don't take their pre-exposure prophylaxis because they don't want their friends to know they're on it because there's still a little bit of shame.
Wow.
Yeah.
Okay.
And so to me, those are probably the three biggest things that contribute to it. And yeah.
Thank you for that.
Yes, so knowledgeable.
Yeah.
I want to know what the streets talking about, T.
So listen, we got our good girl Joy outside. Joy is outside down on U Street in the rain. Thank you, Joy, because Malachi and I wasn't trying.
Wouldn't
to
have been my hair.
Hello, mine neither. But listen, let's see what the streets are talking about. Let's see what myths are out there. So we'll come back and our guests will be able to answer those for us. Be right back.
So Anthony, welcome to the Positive Voices podcast.
Thank you.
So we are here on the streets to ask you about what you know about HIV and dating in the DMV. So my first question to you is, can HIV or AIDS be cured? Yes or no?
No.
Bryce, what you think? Because, the girls out here seeing Magic Johnson been cured for years.
Hello.
My gut feeling is to say no, HIV cannot be cured. Like I've been dealing with HIV for a very, very long time, and it's not something that I would say is curable. But I will say that I think it's been the third or fourth case of HIV that has been eradicated from a person living with HIV through bone marrow transplant and some other things going on. I think this was first discovered for someone who was living with HIV, but also was diagnosed with a bone cancer or a blood cancer. They got a bone marrow transplant, and then it seems like they couldn't find the virus in the body anywhere.
Wow.
So that was patient 0. I think there's been the Pittsburgh patient, and then there's one from Europe. But in general, when we talk about the cost and the hassle that went into them being quote unquote cured, it's not feasible to say that HIV is curable. And I also know that there have been instances where people have been deemed cured of HIV, not living with HIV anymore, and then the virus was found. And I think that's one of the things, what makes vaccination for HIV and what makes U equals U so important is that the virus can hang out in organs. So even when you completely change the bone marrow and the blood, and it looks like it's gone, it doesn't always necessarily mean that it's gone. So in general, I'd have to say no. HIV is not curable, but there are instances where people living with HIV have had some extraordinary medical procedures that have made them HIV negative for the time being. That's going to be my answer.
Thank
Fair.
All right. So who is the largest group of people diagnosed and living with HIV in DC?
I would say African American black men.
He's
What you
right,
think?
but he's exactly right. But I would even make it. I would put age and gender of sex partner in there. So it's basically young black men who have sex with men are where we're seeing the most number of new cases.
Okay.
And it's sad, but I work with the DC Department of Health. We provided HIV screening at both Black Pride and Capitol Pride, and we identified 3 new HIV infections, all in young black men who had sex with men, gay guys that were less than 21 years of age who had never tested for HIV before.
Wow.
So that really is where, we need to be getting the medicine to prevent HIV. That's really where we need some education. That's really where we need honesty and transparency within families, within faith-based networks, whatever it happens to be. They need to be talking about this because one of them was 18 years of age. I mean, it breaks my heart. So,
Who would the second largest group be?
it's a good question. And I'm going to say, I think, without knowing, because I did not look at this before I came, I think that it's black women.
You're correct.
Yeah. I think,
You're
Ding,
correct.
ding, ding, right?
and I want to say that that's a huge issue. And so I'm glad I got it right. And I'm glad we're talking about it because we run the PrEP clinic. We have the PrEP clinic, the publicly funded PrEP clinic. We have a very difficult time getting black women to start PrEP and stay on PrEP. If they happen to be in a discordant relationship, if they happen to be with a man, a husband, a partner who's HIV positive, then they get it. They need to be taking the medicine. But outside of that, they don't seem to think that they're at risk, even if they've had gonorrhea or chlamydia or syphilis, even if they've had other sexually transmitted infections, they don't seem to think that they could get a sexually transmitted infection, which happens to be HIV. So I think that there's, it's good to be letting people know that.
Now I'm gonna throw you with a wild question. Why do you think that is? Why do you think that black women don't do preventive, rather?
I think part of it is defense mechanism. I don't think any of us want to think. So I have been sexually active since the late 80s. I have never had sex in a time where HIV wasn't an issue. And I think anything we can do to minimize the threat of that is going to help us be sexually healthy, And so I think part of it is that they don't want to consider themselves to be a high-risk group. The women who I have taken care of in the PrEP clinic who have been on PrEP because of their discordant partnerships, when that ended, they're like, I'm no longer at risk. I don't think I'm at risk. And data doesn't seem to convince them. It's a personal decision.
Thank
So
you.
saying that black women in Washington, D.C. are at the second highest risk of HIV doesn't seem to resonate with them.
Yeah, they're like, not me, girl.
Not me.
Not me.
Somebody else.
Yeah, but then you until as a person who's formerly DIS, till I'm calling you as a disease investigator to tell you, no, you, girl.
Yeah.
Right.
You. Yeah.
Hey, let's see what else we have on the street. Joy, what's your next question?
Okay, welcome to Positive Voices, Nay and Amaya. Do y'all know what PrEP is? Okay, what is PrEP?
It's like if after you expose to HIV, you take it afterwards to like prevent it or something like that.
So was she right?
She's so close.
She's so close. I was
Okay.
like,
I'm like rooting for her. So she's close.
Okay.
The way that she described it, there are 2 ways to prevent HIV. There is pre-exposure prophylaxis, which is where you take a pill on a regular basis to prevent getting HIV in case you happen to be exposed.
Okay.
So, we were initially rolling out pre-exposure prophylaxis or PrEP among individuals that are high risk, quote unquote. And I hate that term, but high risk, and you can there are several ways you can be considered high risk. You've had a bacterial STI recently, gonorrhea, chlamydia, or syphilis. You have unprotected anal intercourse with people that you don't know that well. You have multiple partners. You have you have sex while you're drunk or you're high. You engage in commercial sex work. You've been incarcerated. Like, there are a lot of different criteria. So that's where you take a pill. Like, you haven't been exposed. The risk hasn't happened yet. You just take a pill because it may happen.
Okay.
And if it does happen, you don't have to worry about it because you're taking the pill to prevent HIV. What she described is post-exposure prophylaxis.
Okay.
So post-exposure prophylaxis has its roots in healthcare because ever since we've been dealing with HIV or hepatitis or other blood-borne pathogens, we have had needle sticks or incidences where healthcare providers have been exposed to the virus and run the risk of becoming infected with that virus.
Oh,
So
okay.
when they have for example, working in a Kaposi sarcoma clinic at AIDS Health Foundation in the mid-90s, you are working with a man who's got KS in his brain and he's a little demented. So he he basically behaves in a way that leads somebody who's taking care of them to get stuck with a needle that just came out of his arm that was giving him medicine for his KS.
Okay.
So that person, that healthcare provider, now has a large bore inoculation through their skin into their system, basically, that has HIV in it.
Oh, okay.
So that is it's a incident that could lead to HIV infection, and so you take a medicine afterwards to prevent it from happening.
Okay.
Right now, post-exposure prophylaxis, we have a PEP hotline in Washington, D.C. We are very much ahead of the game in the DMV, but that requires taking 2 pills once a day for 28 days. So post-exposure prophylaxis, what she's describing is taking 2 different HIV medicines once a day for 28 days.
Okay.
That works at preventing HIV if you have a high-risk sexual event where you may have been exposed. Pre-exposure prophylaxis is either taking 1 pill every day, just 1 pill every day, or now we have injectable PrEP. It's coming around where you would get an injection every 2 months.
I have another question to follow up for that. So the 2 pills a day for 28 days, what if you have another incident within those 28 days? Do you start over?
It's a very good question. And we encourage people to remain abstinent for those 28 days because they don't know ultimately how this is going to unfold.
Okay.
So we do rapid HIV testing and we do 4th generation HIV testing when we start the post-exposure prophylaxis, but there's still a very, very small possibility that they could seroconvert, could become HIV positive during the duration of this therapy.
Okay.
And it could be because of an exposure before what they actually think is their high-risk exposure.
Okay.
So we encourage people on post-exposure prophylaxis to try and remain abstinent during the course of their therapy. Because then they come in at 28 days when they're done, and we do the HIV testing again. And then if they're negative, we know that they're negative for sure. And at that 28-day visit, we try to start them on pre-exposure prophylaxis.
Got you.
So that it doesn't happen again.
Thank you for that. Joy, what you got?
True or false? Is it okay for you to have unprotected sex with your partner if y'all both have HIV?
I mean, I'm going to be very honest about this question. There's no right or wrong answer, and it's a personal decision.
Yeah.
And what I mean by that is that 2 HIV positive individuals who don't want to use condoms and are in a loving relationship, there's no reason why they can't have unprotected sex or condomless sex. That's my opinion, basically. And I think that it's a personal decision. And I will give you an example. In the pre-exposure prophylaxis clinic that I run, I have a patient who's been on daily PrEP for 3 or 4 years. He has taken a pill. He's had lots of boyfriends. He's been diagnosed with gonorrhea, chlamydia, or syphilis multiple times. He's now in a relationship with an HIV positive individual who's on medication and undetectable. So he wants to stop PrEP. Like, his decision is, I know this man's HIV positive. I know he's undetectable. My risk of getting HIV from him is 0. We're monogamous. I don't want to take PrEP anymore.
Okay.
So that's a personal decision
That is
for
personal.
him.
Yeah.
And so I don't think that there's a right or wrong answer to this question. I think it depends on the person. It depends on what your comfort zone is. So that's my. And the other thing, sorry, but you're probably going to say this is, that is a form of safer sex for some people, is what's called serosorting. And so not only searching out partners that are known to be HIV negative or HIV positive based on what your status is, but also having sex in ways that minimize risk. So the HIV positive partner would be the receptive or bottom partner, and the HIV negative would be the top or insertive partner.
Okay.
So, it's a personal. It's a personal decision. And I think that there's a right or wrong answer to this question. I think it depends on the person. I think it depends on what your comfort zone is. So matter.
And you're
decision.
saying serial sorter.
Sero sorting.
Okay,
And
serial
the
sorter.
sero is SCRO, and the sero is based on your serology as to whether you're HIV positive or HIV negative.
Got you. Thank you. Joy, what else you have out there?
Since I only have had oral sex, I am not at risk for HIV. True or false?
False.
That is false. Yeah. Okay.
Don't be putting random stuff in your mouth.
I love how quickly they answer.
Yeah,
that.
if you only so if you just a munch, what is the risk?
Yeah.
So I will say that there is definitely risk associated, but when you talk about all of the behaviors, it's probably the least risky that involves touching or engaging with another person. Obviously, things like masturbation and mutual masturbation where there's no touching, or frottage where there's touching but there's no exchange of body fluids, probably less risky. But when you're talking about the strata of risk for HIV acquisition or transmission, it is the low-hanging fruit. And I know that, one of the many successes of the quote-unquote safe sex campaign of the 80s and 90s was that people knew that of all the types of sex you could have, oral sex was low risk for HIV, and that was even before U equals U or, undetectable means untransmissible. So I love how quickly they answered. There is some risk there. And of course, that risk depends on things like the viral load of the person who happens to be, inserting their penis into their mouth. Has to do with whether or not the gum disease and the oral health of the person who's receiving the penis,
And if you swallow,
Hello.
I mean, call a thing. Some people, because I ain't doing it. I mean, you got to be my man. But I can't be out here just doing it. Like, I'm going to be like, did it erupt? Take it away.
That take it back.
But that does change the risk factor, right?
Yeah,
Yeah.
totally.
Joy, what else you got outside?
True or false? STIs can only be transmitted when symptoms are present.
False.
Yeah.
The biggest symptom is no symptom.
Oh,
First of all, he is fabulous.
hello.
I love
He
everything
showed
about
up.
that person.
Yes, fabulous.
Yes.
Let's bring that person in.
So was they right?
They are right.
Okay.
And I think, it's interesting because Joy is she's bouncing back and forth between STD and STI. And I appreciate that because I'm old school and I'm just ingrained with STD, but the preferable term is STI.
And is that the same?
No. So STD is sexually transmitted diseases. STI are sexually transmitted infections. And the reason why we prefer STI infections now is because chlamydia is known as the silent infection. A lot of us have chlamydia and we don't know that we have it. And even so we can have chlamydia and not know we have it, and we're still at higher risk of acquiring HIV if we're exposed.
Wow.
We can have chlamydia and not know it and still have infertility or other problems with our uteruses or our fallopian tubes or those types of things. So it's the silent infection that can lead to disease. So the preferred term is, HIV is a perfect example. You get HIV, you don't immediately know you have it. And before we had treatment, it could be 10 years, it could be 20 years before you started getting a disease, before you started getting any symptoms. So infection is the much preferred term, and it's because a lot of these bacterial and viral infections don't cause symptoms, and you need symptoms in order to classify it as a disease.
Good stuff. Thank you. What else you got, Joy?
All right, so welcome to Positive Voices, Corey and Mary. When you're on HIV therapy, you can't transmit the virus to anyone else. True or false?
It depends. True. If you're undetectable, you're undetectable equals untransmittable.
Hey.
Here, we out here doing the work. Because the
Yes,
people
you
know.
equals you.
They must have been reading my
They was
shit.
outside. You
There's
equals
nothing
you.
I could add to that response.
It
Yeah?
was perfect.
Because the question, it could have been gone either way.
Yeah.
It's not taking the medicine that's going to prevent the HIV. It's having an undetectable viral load that's going to prevent the HIV transmission. So that dude did perfect.
Well, speaking of preventing HIV, because a lot of these questions were centered around what it meant to be negative or positive, and if people were able to contract HIV or seroconvert. What does it even mean to be HIV negative?
Oh, that's an excellent question. I'm glad you asked it. So I don't know what it means, and I think that that's a big issue. I think that when you go on dating apps or sex apps and you see HIV negative, we kind of put a lot of weight on that, and there's a lot of people that put maybe undue emphasis on that, unfortunately, but there's no standard meaning to what that what that means. And what I mean by that, Malachi, is that you have people who have never tested for HIV that call themselves HIV negative because they've never tested positive.
Right.
The other end of that spectrum are people who are taking medicine to prevent HIV who get screened for HIV and other STIs every 3 months. So they're HIV negative and they know they've been screened a month ago, so they have a recent test, versus the person who's never tested and they're HIV negative because they've never had a positive test. And then you have everything in between. I think personally, when I talk about being HIV negative, the way that our ending the HIV epidemic is set up and the way that healthcare and prevention for HIV and treatment for HIV is right now, to me, what I'm hoping that means is that I get tested regularly and I've tested HIV negative within the last month or two.
Yeah, that's a great point because I know a lot of people, especially like a lot of my straight friends, who don't ever really get tested for HIV, and they are proudly like, well, I'm negative, and I'm like, are you stink?
Yeah.
Right.
Do you know that
You
for
say when
sure?
you haven't even been tested.
Right, for sure.
And that's where the conversation. I mean, when somebody says they're HIV negative, that should open up a whole bunch another conversations. Basically, is like when were you last tested?
How do you know?
How frequently do you get tested? What have you done since your last test? Have you injected drugs since your last test? And if you did you share needles? Have you had unreceptive anal intercourse since your last HIV test with people whose HIV status you don't know? Because then they can't be saying they're HIV negative because they put themselves in situations where that HIV negative test that was done a month or two ago means nothing.
Can I ask why anal sex is more risky?
Anal sex?
Or so risky, rather.
So there's probably two main reasons. The first is that the rectum tends to be more sensitive. It basically tends to be more sensitive. There tend to be cells in the rectum that are more likely to be infected with HIV if exposed than the mouth or the vagina or some of the other holes we stick our penises in.
Yeah.
And then oftentimes, or not oftentimes, depending on the person who's receiving the penis and how big the penis is and other things, it could be traumatic. Which means there could be tearing, there could be bleeding. Yeah. And then I'm going to add a third that I just thought of, is it depends on rectal prep. And so you have a lot of people that prepare their rectums for receptive anal intercourse, and in doing so, they cause micro damage or they cause damage to the rectum in the area that then makes it more likely for them to become infected if they're exposed to the virus.
Wow.
And by prep, you mean cleaning out? Like,
I mean, yeah.
By cleaning out. Because I don't know if everybody knows.
It's preparation,
It's
not
preparation.
Prevention.
Right. Like, because there's another type of, so for example, I prefer lube injectors to prevent tearing. So I'm like, silicone lube injector, get that silicone lube up there, because what you're not going to do is tear up the house.
Yeah.
Down there, you ain't going to come in like a wrecking ball. Okay, you are not Miley Cyrus. Thank you for that.
Question for you.
Yeah.
So do condoms prevent STIs?
Condoms prevent some STIs, and it's a really good question. I think that in general, condoms are very good at preventing the transmission of sexually transmitted infections, including HIV, that are transmitted through body fluids.
Okay.
So ejaculate, pre-ejaculate, vaginal fluids. So it prevents gonorrhea. Very good at preventing gonorrhea. Very good at preventing chlamydia. Very good at preventing HIV. Because those are the 3 STIs, 2 bacterial and 1 viral, that are primarily transmitted through body fluids. It's not so good at protecting against sexually transmitted infections that are transmitted through skin-to-skin contact.
Okay.
So here you're talking about things like the bacteria syphilis, you're talking about things like the viral HPV for human papillomavirus, which causes warts and cancers, and you're also talking about herpes simplex, HSV 1 or 2. 1 can cause cold sores, 2 can cause genital lesions, but 2 can cause cold sores and 1 can cause genital lesions as well. But they're transmitted through skin-to-skin contact. So a perfect example is during syphilis, several stages of syphilis, you can have a sore on your penis or your vagina, but then you can also have lesions in your mouth. So you can have a condom down there, and if you're making out with the person, those lesions in the mouth are filled with the bacteria that transmit the disease.
Or having oral sex without the condom.
Or having oral sex. So wearing the condom is not, I do a presentation, and in the presentation, one of the syphilis is characterized by sores and rashes. And one of the slides of a syphilis case is a man with a big chancre on his lip. And so I put that slide in there specifically to address this point, that if that man wears a condom and has sex with a woman, that woman's still going to get syphilis because the infection, the transmission's occurring from the chancre on his lip, not from anything on his penis. So great question, and it depends on the sexually transmitted infection.
Excellent. So I have a final question. We talked this season to women around HIV and the connection between that and pregnancy. In your professional opinion, can women who are HIV positive have babies?
Absolutely. I mean, actually, in all honesty, it's a little disheartening to me that in 2023 we're still asking that question.
Same.
So that's my gut feeling. I've worked in Africa. I've done a lot of stuff in Africa, usually around sexually transmitted infections. But when I actually did polio eradication and measles morbidity reduction in Botswana in 2004, and one of the big pushes over there was the prevention of mother-to-child transmission of HIV. So these were HIV women living with HIV who were having babies, and they were doing everything they could to prevent the virus from being transmitted from the mother to the baby. So it's been going on for a very long time, and it's definitely doable. So yes, you can have a baby if you're HIV positive, especially if you're in care and you have an undetectable viral load.
Bryce, I can't let you leave without addressing how people get connected to these resources. If they're listening to you talk about PrEP, they're listening to you talk about DoxyPEP, how do people get connected to these resources, and what barriers are there to kind of prevent people from getting access to them?
So it's a great question, Malachi, and I appreciate the opportunity to talk about this, but there should be no barriers in the DMV. And so I want to be very clear that if you're interested in pre-exposure prophylaxis for preventing HIV, or you're interested in HIV comprehensive care, taking medicine to treat your HIV, come to the DC Health and Wellness Center. And it doesn't matter, as far as I'm concerned, whether you're a DC resident or not. When we're talking about HIV, either in the context of prevention or diagnosis and treatment, we take care of Maryland, Virginia, and DC residents.
Awesome. And where can they go to access the DC Health and Wellness Center?
It is at 77 P Street Northeast. And so it's kind of like that area where New York Avenue and Florida Avenue all come together. We are in the back of the People's Building.
Okay.
So where the Wendy's used to be and the McDonald's is, I think the McDonald's is on a corner of New York and First. People's Building is right across the street, and then we're on the back side of that. So the actual address is 77 P Street Northeast, right off of North Capitol, right off of Florida.
Thank you, Bryce. And he's going to be there if y'all get there. So he'll meet you there. You can get all this wealth of information right there on 77 P Street at the DC Health and Wellness Center.
Well, there you have it. Listen, thank you so much to our guests for being here today. Another great episode of Positive Voices. I was your host, T. Pearson Hall.
I'm Malachi Stewart.
And we want to just thank Bryce for being here today to talk about all of the myths that go on in the community as it relates to STIs, STDs, HIV, and AIDS. So listen, if you want to get connected, you want some resources, we have you covered. Head on over to linkudmv.org. You put your zip code in, you'll be able to find all kinds of resources. As Malachi said, if you need a ride, they might be able to help you out. If you need some rental assistance, they can help you out. If you need some clinics, they have you covered there as well. Also, you may want to say, we need some more information. We want some statistics. We want to hear more about what Bryce was talking about. Head on over to DCNsHIV.org. You'll be able to get all of the things that you want there. If you want to check out Malachi now a little more for season 2, click the podcast button at the top. You'll be able to find more of Malachi and I as well as season 1. We'll catch you guys next time. Positive Voices season 2.